It is that time again on a Tuesday to get into the conversation around global health. And today, again, I have my collaborators from all over the world. And of course, like we say, what should I say on the streets? The usual suspects. Dr. Uche Chukwugwaba is here with me this morning. Doc, good morning to you.
Good morning. Glad to be here this morning.
Glad to. But I think you should be paying us some kind of, not royalty, it's some fee because we bring you back to Nigeria every Tuesday.
My brother, this is you don't even understand how much this is important to me.
Good to have you join us. Good to have you join us.
Thank you. Thank you.
Great. And we have someone else joining us this morning, as we do every Tuesday. But before I go to my other guest, remember that Dr. Uche Chukwugwaba is an assistant professor at the Lincoln Alexander School of Law, Toronto Metropolitan University, and managing partner at Marshfield Legal Practitioners, a transnational law practice with offices in Lagos, Abuja, Busan in South Korea, and Toronto in Canada. His pedagogy is informed by critical decolonial perspectives. He taught as a sessional lecturer in 3 Australian universities for about 5 years, and his scholarship engages multidisciplinary comparative and social legal methods in exploring complex questions affecting health governance framework in the global north and global south. Dr. Ngwaba currently leads a program of research focused on advancing a regional health governance approach in inter-American and African human rights systems, respectively. That is the man that is speaking to us today. He's joined by another lawyer here who is currently a postdoctoral fellow at the Dalanala School of Public Health at the University of Toronto under the prestigious Public Health Black Postdoctoral Fellowship Program, as well as being an open air research fellow affiliated with the University of Cape Town and University of Ottawa. He's called to the Nigerian bar, where he has practiced law for many years. He obtained the Bachelor of Laws at the University of Lagos, prestigious University of Lagos. He also holds a Master's in Law, a PhD in Public Law, as well as a Master's in Public Health from the University of Cape Town, South Africa. He is an interdisciplinary scholar and advocate interested in questions at the intersection of human rights, public health, global health governance, and intellectual property. He is a man that has many hats on. That is Dr. Omowamiwa Kolawole. He's the second panelist that we have with us this morning. Good morning, Doc.
Good morning. Thank you very much for having me.
All right, great. I don't have to call you Doc or the law, but thank you for joining us.
Not a problem at all. My
Great,
pleasure.
great. Great. So today we are having a conversation as around health as usual, and it's something we've touched on at different points of our conversations in the last 4 weeks. We're looking at strategies for strengthening vaccine manufacturing capacity in Nigeria and across Africa. And I'd like to start with Dr. Gwaba here. When we talk about strategies of strengthening, I think we should first of all even look at where are we with health care? Where are we with what do we call this? Where are we with vaccine manufacturing in Nigeria, first of all?
Thank you very much, Kayode. This is a question that I think requires us to really pay a bit of attention to, because many of us recall our experiences with the pandemic. When the pandemic happened, Nigeria and many other countries on the continent, for that matter, did not have an immediate response to what was happening in terms of, a response from our pharmaceutical industrial complex, if I can put it that way. And this was mostly because capacity in these sites hasn't been over the years developed to the point where you can say that Nigeria had a viable pharmaceutical industrial complex that was capable of responding effectively developing some sort of therapy for the virus, the COVID-19 pandemic. The other thing also to note that is that, our research and development industry or sector, in the pharmaceutical space is at best, at infancy. At worst, I would say it is severely understaffed, underfunded, if you compare obviously with what obtains in other advanced countries, countries in the global north, as we like to refer to them. And so what this has meant is that, for a very consequential pandemic like the COVID-19 pandemic, Nigeria really had no domestic capacity, to formulate a response based on the science, based on, taking appropriate, therapies, to respond to the virus. Compare that to what was happening in the United States, where U.S. President Trump was able to, fund. He brought the warp seed that was, given to pharmaceuticals, and that, drove the research that eventually led to the COVID vaccines that, we began to sort of use around the world. Germany did the same thing for its industry. The UK did the same thing for its industry. Even in Australia, there was a bit of investment, in this area. And so, to your question, where are we? I would say we are not where we are supposed to be. Do we have an pharmaceutical industrial complex in Nigeria? Of course we do. Nigerian researchers have, been researching for years on tropical diseases and so on and so forth. For example, when Ebola happened, the reason why Nigeria was able to respond is because Dr. Oladevo was able to call upon the expertise of, certain Nigerian researchers who were, researching the field to consult and say, these signs and symptoms that are presenting, what does that look like to you? So the presence of a pharmaceutical research complex is a question of national security. And unfortunately, this is one area where we have dropped the ball.
Wow.
And perhaps Dr. Wami can actually shed light on this, because this is an area where he researches significantly.
Thank you very much, Prof. So to the question, I think it's a very interesting question and also very poignant question, especially considering the fact, like Prof said, that Africa was left with being at the mercy of the global north when it came to getting access to COVID vaccines. But it's important to also note that steps are being taken or have been taken since COVID happened. And one important step was to try and fast track the ability of developing countries, many of them being African, fast track their ability to develop their own vaccines. And based on the fact that a lot of African countries were on the back foot with regards to the know-how, the technological capacity to maximize mRNA technology, which is the vaccine technology that was the basis for COVID. The WHO, in alliance with some European countries and NGOs, funded a project called the mRNA Hub in South Africa. And the purpose of that hub was to fast-track vaccine manufacturing capabilities in about 14 or so developing countries. Nigeria, interestingly, was one of those countries that was meant to go to South Africa, learn how to make an mRNA vaccine, and then come back home and manufacture. But what we have seen is that since that visit, not much has been done. So the question then is it a question of skill? If it's a question of skill, you have been taught the skill, or is it a question of finance, or is it a question of political will and the interest in allocating resources to that? So those are questions that we need to look at and we need to explore. What then do we need to go from the skills gap to implementation to prepare us? It may not be that we are creating vaccines for the world when the next pandemic happens. It may just be that we are creating vaccines that are relevant to our climate. For example, we saw that with the COVID vaccines, one of the major problems that we had was the ability to cool those vaccines, to refrigerate them. Maybe the niche that Nigeria brings is that we explore vaccines that can withstand uh, temperate climes, which is how many African countries are. So it may not be that we are competing with the big pharmaceutical companies of the world. It may just be that we are offering a niche, or we are dealing with diseases that are peculiar to West Africa or Africa at large. But at some point, Africa needs to build its capacity. Nigeria needs to build its capacity. We need to be the center, the economic center that is working with our neighboring countries like Ghana, Benin, Togo, and the rest of them. Because ultimately, while we want to collaborate with other African countries, we also need to play our part in our region. And that means that we need to leverage the skills that we've gone to learn in South Africa, and then work on developing capacity for our local context.
All right, and I'm going to ask a very ignorant question here. Someone who has no knowledge of health, someone who has no knowledge of international diplomacy and the interaction between the global north and the global south when it comes to health as well. Now, when you were speaking, and I thought to myself, what are the steps to vaccine manufacturing? I assume there'll be research, there'll be the testing stage or the trial stages, then the full manufacturing. Can we work
Yes.
with those three steps?
Yes. Yes.
Okay, so if we're working with those the three steps, I was just thinking that, okay, just like the saying goes, you can't do it all.
Mm.
Must we go into manufacturing? What if, like you said, we've gone to learn the expertise, we know how to do the research, we know what we need here, we do the trials, and we partner with big tech or vaccine manufacturing companies abroad to say, we've done all this, this is what we've done, let's go ahead and have you manufacture this for us. Will that
Let
be
me
a wrong thing to do? All right.
let me give a first start at this, and then I know that Dr. Wami will definitely have a lot to contribute to this. Let me approach this question from the dynamics of the politics of power, which we have always been sort of grappling with throughout our engagement on this program. You see, Kayode, the problem with global health is that if everybody does what they're supposed to do, okay, if everybody follows the agreements, the understandings, the international treaties that have been put out there to envisage periods of health crisis, what needs to happen, then I would say, well, there's a lot of logic in what you're saying. Okay. The danger and the problem, and we saw that happen. This is not a hypothetical problem. We saw that happen during the COVID-19 pandemic, is that when crisis happens, the first thing that goes out of the window is principles of solidarity. Because what you're mentioning is about principles of solidarity, international solidarity. One of my mentors, Professor Obiora Okafor, he was, at the time of the COVID-19 pandemic, the UN independent expert on international solidarity. Maybe one of these days we'll bring him on the show to share about his experiences in trying to convince countries of the world to cooperate in solidarity during the COVID-19 pandemic. He delivered a lot of reports, high-level reports at the level of the UN General Assembly. Now, we saw what is the report card from the pandemic. We saw during the pandemic many pharmaceutical companies that you reference opposed the idea of allowing access to generic to the patents, the information or the research to allow for generic versions of the vaccine to be produced. What we're saying is that you have produced all of these brand names, allow us to produce no brand names of the same quality that we can sell at a cheaper level or at a cheaper price to low-income countries on the developed countries. The United States, Canada, and many and Europe, where most of these pharmaceutical companies are located, said no. That they preferred to protect their intellectual property rights. They said instead, what the government should do is they should provide more access to funding so that these countries can have access, can purchase these vaccines. But you see, the problem during the pandemic wasn't about funding to purchase the vaccine, because you had the COVAX initiative where countries had donated funding. The problem was access. Who gets it first? Okay? And so what you then had was politics of power coming into play, where we now started having vaccine nationalism or vaccine apartheid. Countries were hoarding. Canada was hoarding stockpiles of vaccine to boost its populations 3 or 4 times over, while countries in the developing world did not even have the first dose for their frontline workers. We're not even talking about the entire population. We're talking about their frontline workers. So the point I'm trying to make is this. If we do not develop our local capacity, if we do not invest in the infrastructure to make sure that we are in charge of our own destiny, when another crisis happens, countries will then remember that they need to protect their population first. In the global north, they framed it as a global health security problem. Meanwhile, the proper framing should have been about global health access, human rights, global health equity. But all of those things were thrown out of the window alongside solidarity. And there lies the problem. And that is why, to prepare better for the next health crisis, Nigeria needs to develop its own capacity. Africa needs to develop its own capacity so that we are not held ransom by global north interests who do not regard us as equally deserving of the same access to opportunities for, protection of our health. As I said a couple of episodes ago, the paradigm is that some lives are more important than others. I borrowed from Animal Farm. I say all animals are equal, but some are more equal than others. And that's the reality. It's an animal farm out there.
Wow. An animal farm indeed. Doc, let's hear you.
So I was just going to latch on to Professor Uche's point, and I think beyond the general global politics of global health governance and vaccine access, I think the South Africa also is a cautionary tale, because South Africa, for example, had that capacity that you are talking about, which is the ability to be a licensee for a big pharmaceutical company. They already had fundamental generic manufacturing capability. So they and India were one of the countries that were at the forefront of making the case for generics and for waivers of vaccine patents. But what we saw was that those big pharmaceutical companies were working with local South African companies to create their own vaccines for them. So while the South African population and even people that were working in those labs did not themselves have access to the vaccines that they were producing, not only did those local South African companies not have the ability to produce vaccines for themselves and for the local South African population, those vaccines that were manufactured even in South Africa were still sold as if at prices as if they were being imported. And so what you had was a licensing agreement. So the problem with licensing agreements is that ultimately the intellectual property still rests with the company that has been given. So Nigeria can get to the stage where it can license from big pharma to manufacture, but if the intellectual property is not situated within us, ultimately we are going to have a replication of the same kind of problems where we are dependent on the largesse and the altruism which we have seen that the global north does not have for us. So ultimately, and there is a market case to be made for it ultimately, because if, for example, we are a major manufacturing hub and we say we will supply to all West African countries, there's a large enough population to justify that investment. And so we guarantee access for our local citizenry while catering to the needs of our immediate neighbors. And I think that also aligns with the work of Professor Uche around building regional governance mechanisms. And so being good neighbors goes beyond diplomacy rhetoric. It also goes towards action. If the next pandemic were to happen, how can Nigeria be a true giant of Africa in the context of supplying and producing vaccines? So ultimately, while your question is valid and that is a possibility, it does not guarantee that when the next pandemic happens, Nigeria will be secured, Nigeria will have access to vaccines. We may end up just simply producing to then export out again to other countries who are willing to pay a premium.
All right. So,
before you move quickly to the next question, there's something
okay.
I want to double down on, just to bring a richness, because I think this question you've asked really hits at the heart of a lot of the discourses we're having today.
Okay.
Professor Wami mentioned that South Africa had generic capacity, manufacturing capabilities, and in fact entered into licensing agreements for the manufacture of those products in South Africa. I think it's important. There is a shock element to that statement that I think I need to bring out because it looked like it didn't land properly, which is the fact that these pharmaceutical companies from the West used the capacity of South Africa, but they were producing those products not for South Africans, but for the West. In other words, that's the point Dr. Wami was making. They were producing these products in South Africa, but it was meant for ferrying to the West, okay? And if South Africans were going to have access to those vaccines, they will be sold to South Africa at international market price. In other words, what Dr. Wami is saying that even the people who were working in the labs producing those vaccines could not afford it. That is very consequential. There's another point that I need to draw our attention to. During the pandemic, I secured, together with my co-investigator, Mr. Chiamaka Ojaiko, we secured a funding from Transparency International and Open Society Foundation to undertake an empirical research into vaccine contracts, COVID-19 vaccine contracts that were entered into by countries around the world.
Okay.
The title of that research project was Freedom of Information in the Negotiation of COVID-19 Vaccine Contract. It's been published as a report by Transparency International, and you can also find a copy in a journal, an international journal, the Transnational Human Rights Review. Now, we interviewed a number of stakeholders, across the world. I can't go into the details for, research privacy reasons of the people we spoke to, but we spoke to people who were at the forefront of developing policy, who were at the forefront of implementing policy around COVID vaccine contract. And we made very startling revelations, all of that contained in the report. One of the revelations we discovered was that the prices that vaccines were sold were not the same.
Oh.
Yes, developing countries, poor countries paid more for the vaccine.
Sometimes double, countries. Sometimes triple.
No, wait, hold on a minute. When you say they were not the same, is it based on the social capacity, or you're saying because one would expect that African nations will pay less?
Exactly.
I am not.
But we were paying.
Yeah.
So they would pay. African countries would be expected to pay $32 or $35 per dose, while America was paying $10 per dose, or European countries were paying $7 per dose.
Exactly.
So,
and what's responsible for that?
That happens in. What do you say?
What's responsible for that? As in, because they always looked at as they always looked at as the big brother who always giving aid.
No. That's the point we're trying to make. Exactly. There's no big brother in business. What we're saying is that pharmaceutical companies in Europe and America, in the global north, exploited the COVID-19 pandemic to make humongous profits at the expense of human lives. In fact, if you see reports, financial reports that were produced by, these companies, that were posted by these companies after, during that period, COVID was good business for them. It was rainfall for them. And who were the who were the people that were propelling this sort of massive economic returns? It's poor countries in the global south. I can give you an example. Botswana, for example, paid more for the COVID vaccine than the UK.
What? Botswana?
Yes. African countries were paying more. But then here's the kicker. These contracts were covered by confidentiality provisions. In fact, matter of fact, many of the contracts we were looking at were the clause, the aspects of the contract dealing with price were redacted.
Exactly.
Wow.
Were public documents, but they were redacted. The reason why we were able to see what was behind the redaction was because one or two countries went ahead and published the full contract. That's the reason why we're able to see some of the contract. In other words, the pharmaceutical companies were setting the terms. It was the wild, wild west out there. They were setting the terms.
And in some cases, they were compelling those African countries to put their national assets on the line
as
if
guarantee.
They didn't have the ability as guarantee.
Wait. You mean there was a case of demand for sovereign guarantee to supply
Absolutely.
drugs?
Yes.
Absolutely. In fact, let me tell you something else. In some instances, pharmaceutical companies refused to sell to certain countries because they felt they were not a worthy market. They were not good, they were not rich enough to afford it. For Caribbean states, as an example, Caribbean states could not approach pharmaceutical companies and say, come and do business with us. They say, no, you're not a worthy enough customer. So they have to come kind of come together and do some sort of asusu.
Collective buying.
Okay. And even then, they can't approach them directly. They had to go through COVAX. I don't know how many of you are familiar about COVAX. COVAX was the initiative where WHO, UNICEF was in charge of collecting money, pulling money and resources together to purchase vaccine and distribute to poor countries. So look, the politics is very mucky. What we're talking about here, we're talking about,
is
some
raw
really
power
troubling issues.
I mean, what you've said, it's shocking at the same time not shocking, because I'll say, for example, when the malaria vaccine was released, was it last year? And it was tried in Ghana and some other countries. One of the first things I said to my colleagues was, why did it take so long for a malaria vaccine to be discovered? Because if it were that prevalent in the West, wouldn't we have it already? Why are we so excited about a first malaria vaccine? I felt that was questionable if indeed we were looking at resolving this issue. So hearing you speak about how this entire process was politicized, or not even politicized, dollarized, then the idea of a Big Brother initiative should be reviewed. And so in Nigeria, when we're talking about we'll go to the West, we'll do this, not just in health, but any other way, we really need to look at that. But seeing how critical this is, how important it is for us to get this sorted out. When you look all across Africa, Dr. Kolawole said earlier on how some training was done in South Africa. Nigeria, we are the Big Brother. We have the experts like you abroad. Which country would you say is closest to starting its own a very functional vaccine manufacturing industry? Which country is most prepared? That sounds better.
So I would say Egypt and South Africa. Egypt is already manufacturing its own vaccines at scale. It manufactured its own COVID vaccines. It's well on its way to manufacture its own mRNA vaccines for other disease contexts. But it's also important to note that, like you said, remember when you mentioned the 3-step thing about research and development, getting the approval, trials, and then you manufacture at scale. One of the important steps is getting an ML3 license, and that's an international license. What that says is that your country has the expertise and the technological know-how to not only manufacture, but to ensure that the vaccines that are manufactured are fit for human consumption around the world. So it's a global standard. only 3 countries in Africa have met that global standard, have ML3 status, and it's only when you have that status that you can then manufacture at scale. Nigeria doesn't have it, and so
Wow.
it's almost like saying you want to host the World Cup. You may have the pitches, in
The
different states,
stadia,
but you
yes.
then need
The quality.
FIFA to then come and
Mm.
look at your pitches and say, okay, these pitches are fit for playing football at a global standard. Nigeria has not gotten that kind of accreditation yet. So one of the first things we would need to do is to build that capacity to say we are eligible for ML3 status, and then we can leverage. You don't need every country in Africa. Well, this is my own position. You may not need every country in Africa to have ML, but there should be one in every region. Maybe Kenya, Uganda for East Africa, South Africa for Southern Africa, and maybe
Egypt
Botswana,
for, yeah.
Nigeria and Ghana, and then Egypt and Algeria.
Mm.
But currently, we only just have Egypt and
And
South
South
Africa.
Africa.
So,
And,
so, so beyond doing the research, we need
yeah.
to build that kind of international, globally
Mm.
recognized capacity. Because if we don't have that globally recognized, anything you manufacture is not going to go anywhere. So you're just going to waste your money,
It will be for local
and
consumption at your own risk.
it won't even be fit for local consumption. To be honest,
Wow.
it won't be.
It reminds me of the vaccine that was reportedly or purportedly manufactured during COVID. Is it from one Southern African country? Was it Madagascar, I think? And it was one liquid bottle and was being said to be curing COVID and
Exactly.
but I mean
Local therapy.
the local therapy. No, but when you look at all what we've done, what you've said right now, it's quite shameful that Nigeria is not there yet because we're like you use football. We're doing well in football. We'll even beat South Africa today, fortunately for us, by God's grace. But we're doing well in many other spheres. But the most critical aspect, which is health, it seems we're not doing as good. Although we have many competent experts all over the world, from Australia to Canada to even, I'm very sure if we go to Russia, of course, they are there in
Absolutely.
Ukraine, in Israel. So, I mean, what does it take to get this ML3 status?
Okay. First and foremost, let me jump in, and I'm sure Dr. Wami will have a few things to add, and not specifically about what it takes to get the ML3 status. I'm sure Dr. Wami will speak to that. But then I want to speak to the earlier part, the other part of your question, or what is implicated in your question, which is really about, governance, of the health system. You see, when we talk about getting the capacity, to be able to have ML3 status, what is implicated in that aspiration is very structural, very systemic. Okay, you cannot be talking about, if I use the metaphor of the stadia that you mentioned, you cannot be having the stadia alone or focusing on the stadia alone. You need to focus on the infrastructure, the road to the stadia, housing, accommodation for the athletes who will come in, access to facilities or amenities, to support, fans and athletes from, overseas. In other words, there's an entire value chain that you need to sort of develop. Okay. What we have at the moment is that value chain is broken. As an example, you have a massive exodus of our most competent hands that has been taking place, for a couple of years now as a result of the Japa syndrome. Nigerians have always traveled abroad to seek better opportunities, but it has never been this bad, where entire departments are disappearing, whether in the banking sector, in the hospital sector, wherever, in all the critical sectors of our economy, our best brains and best minds that will power the industrial revolution, that will power strengthening our health systems are disappearing. My mom died during the pandemic as a result of the pandemic, and so I was, I experienced firsthand some of the issues that were at play. One situation that stuck with me was, at one point when it was being contemplated to put her on life support, my friend who was the medical doctor, I discovered by accident, was the medical doctor in that hospital. He now was telling me the backstory. It was like, my friend, dude, the situation is that there is a one life support machine. But the people who could operate it have left the country. They have japan.
What?
Yes. That okay, he probably would be able to operate it, but then that's probably that he was not on shifts at the moment. He's gonna come the next day. Unfortunately, she passed before that happened. And so the point is that you can see how something as simple as, it's not that we don't have the life support machine. So who will operate it? Only one doctor could do so. The rest had left the country. So that's where we are. That's where we find ourselves. So to your question, what do we need to do? I think that the first place we need to start is we need to start in our human capital investment and development. It is not that Nigerian medical schools are no longer producing very good doctors, but the problem is that the moment those doctors are produced, they are dusting their certificates to go and look for better opportunities.
So doctors are now like footballers. You play one season
absolutely.
in Nigeria,
in fact, they are even more valuable than
Tanzania.
footballers these days. Yes. Exactly. But then you see, the answer to that is not to do what I think it was which minister of health, I can't remember now, saying they're now going to regulate migration opportunities for doctors and make it impossible for them. That's not the solution. It's not the solution. Capital labor will always go after where it is rewarded. Exactly. That is what globalization has brought about, that the world is now a global village. That, what business do I have, plying my trade as a professor in a Canadian institution? But for the simple fact that here, my talent will be better utilized, I have better opportunities. Otherwise, I should be lecturing in the University of Lagos or any of the universities in Nigeria, as an example. So that's the reality. And so what it means is that we need to kickstart a process that will lead to the reverse migration of competent hands. And I can tell you that you only need to make Nigeria work a fraction, and you're going to see a massive reverse migration. It happened previously during the Goodluck Jonathan administration when things began to look up, the economy was looking good. In fact, starting from the Obasanjo administration, when, he put in place some policy reforms, and so on and so forth. Nigerians started coming back in droves from the diaspora to take up positions in public service, in the public sector. Many early ministers in that administration were returnees, who were coming to take up opportunities. And so let me end my remarks there and allow Dr. Wami to respond to the other part of the question.
All right.
Yeah. So I think the point Professor Uche makes is a very important one. And I think ultimately it boils down to political will and capital. So also dialing it back, for example, I don't know if our audience knows, beyond the global issues around health, there is a local reality of the ability of the average Nigerian to walk into a public health facility, a primary healthcare facility, and receive basic care. Even if we were to have those vaccines would be delivered at the local government level by primary healthcare centers. What nurses are in those primary healthcare centers? What doctors are in those primary healthcare centers? Nigeria now has a right to health. How far can the average Nigerian say, I am enjoying the rights to healthcare? That I can walk into, we every time in the news we hear about people who are shot on the road and they go to the hospital refuses to treat them, even though there are laws that say that you cannot reject a victim of a gunshot wound. We have situations where women go to the hospital and because they are unable to pay, they are left to die. Whereas maternal care is one of the fundamental parts of the right to health care in Nigeria. And so, beyond seeking ML3 status, which by itself would require serious capital investment and political will, you need to build a system, a healthcare system that is able to, so for example, even beyond ML3, the ability to do R&D, research and development. So you would do research in the labs, but at some point you would have to do research for sizable populations, 1,000 people, 2,000 people, 3,000 people, before you then do it at scale. How many of our teaching hospitals have that capacity to do that kind of 1,000 people research to test the efficacy of a drug that has been manufactured, to do that kind of R&D. And so ultimately, what we need is state capacity, both for building ML3 status, because that means that you have the facilities in place, you have the infrastructure, you have the human capital. But at the same time, we need to build our health systems so that even when we then have a pandemic, it doesn't crash, the health system does not crash under the weight of trying to address that situation. We had a situation where there wasn't oxygen for people, and so many people died. So it wasn't even an issue of there are interventions you can make even before the vaccine is there. So we knew that COVID was affecting people's ability to breathe, but then there weren't oxygen tanks. So it wasn't even a case of administering those tanks. I mean, for not to be dismissive, but just about anybody can put on an oxygen valve and you wear it on your nose. So it's not even as complex as a life support machine. But if there is no tank, what then happens? And then you had people buying tanks at exorbitant prices. There was now a mini tank black markets in many states. So ultimately, what needs to be done is that we build capacity structurally, both for the ability to manufacture vaccines, but more importantly, to strengthen our health system as a whole. Because even if those vaccines come, the ability to administer those vaccines will be through the local health system, the health system structure that we've already built. And so for me, I think the issue is about going back. And like Professor Uche says, okay, one of the problems in the study that we conducted in South Africa with my colleagues at the University of Cape Town and the University of Ottawa, even in South Africa, that is slightly more developed than Nigeria, part of the problems they had with their ability to manufacture vaccines was the amount of money that was being spent in other issues that ordinarily they shouldn't have to spend money on. So South Africa has started to experience power outages, and you cannot manufacture vaccines without electricity. There are certain compounds that need to stay cold 24/7. You need a cold lab. So if, for example, you are spending 500 million on just paying for generator maintenance and fuel and all of that, then you're already eating into your profits or your margins, and that would then reflect into the amount you can charge. And we both know that nobody's going to pay $20 per dose for a locally manufactured vaccine. The same way they would pay, they'll be more willing to pay $30 per dose for a vaccine that is coming from the West. So if your unique selling point is your margins, that your vaccine is as efficacious but it's significantly cheaper, that needs to replicate down the value chain. So your money is better spent in bringing and retaining talents than on things like paying for electricity, paying for security that your company doesn't get vandalized, paying to ensure that you have to fly it instead of using the roads because the roads are not safe and it can cause a hazard. So things like that. And so ultimately, it's a structural thing. You cannot build one without building the other, because there's going to be a ripple effect, a domino effect that is going to ultimately tell in your pricing and your ability to act fast, timelessly. So those are some of the issues that we need to tackle.
I see Prof wants to chime in a bit.
Yes, one other fundamental area we need to pay attention to, and I think Dr. Wami hinted at in his intervention, is research and development. Now, in Canada, for example, the government funds research extensively. You have a funding body funding social science research, the Social Science, Humanities, and Research Council. You have a funding body funding health research, the Canadian Institute of Health Research. You have a funding body funding engineering research, NSEC. In other words, what we're saying is that you need to put your money where your mouth is. Okay, you cannot be talking about having the capacity to manufacture vaccines when you cannot, provide even the basic funding for research. I worked in the public and in the academic sector of Nigeria, and I can tell you for a fact that there are no equivalent funding bodies for research in Nigeria the way that we have fully established in Canada and many other Western countries.
I mean,
where on a
that's
yearly
understandable,
basis,
Prof. We look to God for everything. God will provide when it's time to research. God has a way of showing up.
I suppose we fund offerings in churches and pray for a miracle. But on a serious note, though, this is something that we need to, at a very basic minimum, in as much as Dr. Wami has flagged a lot of structural issues that need to be addressed. If you ask me the question, where do we start? This is a low-hanging fruit where we can start from, because we can develop research and partner with other countries, that have better structures in place to say, hey, we've done this research. Can we combine our findings with your capacity to manufacture and produce something that is competitive in the global pricing market? These are ideas that can be used while we try to, scale up and fix our structural issues. There are low-hanging fruits that can be explored.
All right, and that's important that we speak on this. But before I let you go, just a quick recap. You're saying that while we're concerned about getting the ML3 status, a few things we need to look at. We need to focus on the capacity. That's the number of staff that we have, the professionals that will do all the work for us. Then at that as well, we need to focus on competence, because it's one thing to have the capacity, but to be willing or interested in doing it is a different issue. All this are things we need to consider before we even go after the ML3 status. Now, in Lagos, even as that, I think June, I still saw them, or was it June or July? I saw primary healthcare workers going from door to door, vaccinating kids aged 5 years and below. I think they were doing polio and another one. Now, a lot of these vaccination exercises are sponsored by institutions like the Johns Hopkins University, the WHO, and all that. Will these institutions be willing to fund the distribution of locally produced vaccines?
That's an interesting question you've asked, Dr. Kaida. Are you sure we have time for that
discussion? We only have 2 minutes, so if we can't do it, we might need to push it up.
I think we should reserve this question for because Dr. Kolawole will come back at our next episode.
Okay, great.
I think we should reserve this question to take up at our next episode, because you have just opened a canker worm. I'm not sure we have time to respond to that question.
All right. It's good, and moreover, there are many things we haven't touched on this vaccine business. The impact of BRICS, if that could work in any way. We've not touched on collaboration within African countries. One of my listeners sent a message. Let me just read that. Maybe you can address that. It says, how can we leverage our local herbs?
Fantastic.
That's a fantastic question.
Health. Yeah. Muhammad Ali Pate to come up with a reform that will give our health sector a facelift across board. That is one question. Another person here, Yomi, and that is, one of Nigeria's exports to the world, Benga Shoyemi, who's out there. He sent that from somewhere in Europe. Yomi from Muriokola in VI says, good morning, Mr. K. And nice to hear your voice this morning. Thank you for the guest. Prof is on point. He who fails to plan plans to fail. The European countries are already planning for uproar on Third World War on emergency gadgets or kits. What is the role of the Ministry of Health and the stakeholders in health sectors? If we can produce our dose, why should we allow the others exploit us? That's the question he asked. So on the herbs bit, I think we need to push that as well to the next episode.
Yes, we need to. And in fact, one of these days, we will bring a senior scholar, a professor who has been working at the global stage on this developing a global treaty on traditional
Traditional
medicine,
knowledge, yes.
not traditional knowledge. Professor, would you remind me
Chidi
again?
Ogwagwana.
Professor Chidi Ogwagwana. So he's probably someone I'm trying to snag to bring him to talk to us about the developments that are taking place. They're very important developments.
All right. I mean, hearing you talk about him, an idea came to mind. I think if I know government won't do that, so we the people, we might need to look for a way to get an island somewhere in Cameroon where we could put all of you who are abroad. Just come there. Don't come to Nigeria. Just stay in that island and provide service for us here in Nigeria, because there are so many great professionals now of Nigerian origin. Some don't even have any other citizenship. Some have multiple citizenships, but all they think about is Nigeria, and they keep looking for that person that'll give them an opportunity to serve. Well,
Yep, we're quite right. We're quite right.
yeah. So we want to thank you for your time today, Dr. Omowamiwa Kolawole. We thank you for your time, and of course, Prof.
Thank you very much for having me.
Ogwaba. It's
Thank you
always a
very
pleasure.
much. Always a
Thank you
pleasure.
very much.
Great, great. So we'll be back next week, Tuesday at 11 a.m. Do not change your dial right here on Lagos Talks 91.3 FM. You know, we go to the end of the world to bring you information. Take this information, run with it. We're empowering you to be able to engage your presidents, your leaders. When a governor is coming, particularly for 2027, ask him or her about all these points we've raised concerning health. If it's the president, what do you want to do with health? These are the peculiar needs of Nigeria. And if we ask the right questions, for all you know, we could get the right answers, even from the wrong person.